Welcome back to part 2. Let's keep trucking along and learning more about hematology and immunology dysfunction. Aplastic anemia is basically bone marrow failure. The CBC is going to show pancytopenia, or a decrease in all blood cell types. It can be primary, which means it was present at birth, or it can be secondary, usually due to something like human parvovirus, hepatitis, infection, radiation, immune disorders, chemo, exposure to benzene, leukemia, lymphoma, or it can just be idiopathic, which means we have no idea why it occurred. It just did. Lots of lots of secondary reasons, I know. Treatment includes one, to restore the bone marrow function via a bone marrow transplant, or immunosuppressive therapy to stop any autoimmune destruction. Bone marrow transplant is sort of the first treatment of choice. Stem cell transplants can also be done early in the disease course if available. So in 80% of cases, hemophilia is X-linked, which means it affects males only. Females are the carriers. Why? Because the trait is carried on the X chromosome. Females have two X's, males only have one X. So if they inherit the mom's, I say, bad X chromosome, then they're going to end up getting it. If the females get the bad chromosome, then they just become a carrier. If you do that Punnett square again with big X, little x, and a big Y and a big X, or you can do like, well, it doesn't really matter. It's too hard to try and explain a Punnett square without just showing you guys on a board. But the disease always occurs in the males. Females just usually become carriers. Female carriers do not usually manifest the symptoms of the disease because, again, they have one of the good X's to mask the hemophilia X, but they may have prolonged bleeding during something like dental work or surgery. Diagnosis is going to be overt or prolonged bleeding. Hemarthrosis is just simply bleeding into joints and abnormal bruising. We talked about the X-linked inheritance already, and then it's low levels of factor 8 or factor 9 on labs is what you'll see, as well as a prolonged PTT time. So the treatment for hemophilia is something called DDAVP, which is desmopressin. It's basically an analog of vasopressin. DDAVP stimulates the release of factor 8, which is stored in blood vessels, which increases the amount of factor 8 available anywhere from 2 to 4 times. So that's a very good thing. The other nice thing is it can be given by nasal spray, which is very convenient in dealing with the pediatric population. It is used for mild hemophilia. Steroids can be given for hematuria, hemoarthrosis, and chronic synovitis, which is you guys should look that up. But think about synovial fluid. Think about where you have synovial fluid, inside joints, knees, commonplace. So we want to use NSAIDs with caution. Gene therapy involves introducing a working copy of factor VIII into a patient with a flawed copy of the gene. There are still problems with this, and hence that's why there's no cure for hemophilia yet. If a child is bleeding, we are going to hold pressure for 15 minutes. You know what a good boards question would be? I'll tell you. We'll practice. What would be a good sports activity for a child with hemophilia? Karate? Football? No. We're going to say no contact sports. What can kids with hemophilia play? What teams can they be on? Swimming! Yay! They need to be aqua children. And they can join the chess team. Dental hygiene is important. We're going to use soft toothbrushes. When they're in the hospital, we're going to pad the bed rails. We're going to keep them, we want them to use soft toys. Definitely wear a bike helmet, because if they fall off their bike, A, they were already at risk of getting a head injury, but B, if you don't clot, then you can have a massive head injury. So definitely a bike helmet for sure. We want to teach parents the signs of bleeding into joints, how to manage the bleeding, teach them about their medications, and teach prevention of injuries. This is a biggie. Biggie, big, biggie. Teach prevention of injuries. We want to recognize and control the bleeding, and we use the RICE method for that, which is rest, ice, compression, and elevation. Parents should have cold packs in the freezer ready to go in case of injury. It's important to know that these kids may have some developmental delay due to their physical activity restrictions. We want to prevent crippling effects of bleeding, so when the blood collects in the joints, it can cause immobilization. So after the bleeding has subsided, then we want to do some range of motion exercises because we want to maintain that joint mobility. Aspiration of blood from within the joint space may be necessary, but again, as nurses, we won't do that. PT may be needed or possibly an orthopedic consult. Children have a near normal life expectancy with treatment. And it's important to support the family in the home care. Be especially supportive of the mother. Moms usually blame themselves for this, and I've seen husbands blame their wives for it too. So be sympathetic, be supportive. All right, ITP, also called immune thrombocytopenia. This is an acquired hemorrhagic disorder characterized by, and you can read all this stuff on your slide. I'm not going to repeat it for you. But basically, you have the bone marrow production of platelets is normal, but the spleen gets the wrong signal somehow and it just destroys platelets. So when the destruction exceeds production, our platelet count decreases and we get bleeding, hence the purple coloring. It's one of the most common bleeding disorders in children with the peak age of 2 to 5. This is acute, it's usually self-limiting. Often follows an upper respiratory or other infections like measles, rubella, chickenpox, or after parvovirus B19, which is Fifth's disease. It can become chronic, which means it goes on for greater than 12 months in duration. Okay, I want you guys to remember though that with ITP, the bone marrow production of the platelets is normal. It's the spleen that screws up and just destroys them. Okay? Bone marrow production is fine. The spleen is what keeps destroying them. So children who have ITP are put on an activity restriction so that they don't hemorrhage with their injuries. We will give steroids because it can raise your platelet count by suppressing your immune system. Again, the issue is not the bone marrow, the issue is the spleen who keeps destroying them. We don't usually give platelets because if we give them, what's going to happen? The spleen's just going to destroy them. So it's kind of a waste. We can give IVIG and anti-RHD. If there's no response to medications after 6 months to a year, then they will oftentimes perform a splenectomy. So now we're going to talk about pediatric cancer. I have put some of the ways that cancer is different in red to help you guys distinguish between, between adult cancer and pediatric cancer and see kind of what the differences are. Thankfully, pediatric cancer is not common, but some neonates and young infants do have cancers, such as CNS tumors, neuroblastomas, leukemia, retinoblastoma, renal or hepatic tumors, sarcomas, or teratomas, and those are usually diagnosed right after birth. Because these cancers occur so soon after birth, it is suggested that they are the result of some inherited condition or there is a genetic susceptibility. The bottom line is that in children, the immune system, which normally fights cancer, is not quite ready to fight cancer. In the first month of life, nonspecific immunity, those are your phagocytes and mononuclear leukocytes, your PMN cells and natural killer cells and complement proteins. All of that is immature. The system is just not ready to take on cancer and fight it off. Nonspecific immunity is also impaired if the child was born premature or small for gestational age. For specific immunity, T cells that are supposed to attack specific invaders. Those T cells are immature in babies and immunoglobulins are below adult levels, which makes a baby prone to bacterial and viral infections. Apoptosis normally takes care of cell overgrowth, but that is because most all cells in children are growing and dividing quickly. Because they are supposed to be growing, the process of apoptosis is not always triggered. Acute lymphoblastic leukemia accounts for 25% of all childhood cancers and 78% of all leukemias. Acute myelogenous leukemia, or AML, represents about 17% of leukemias. So, the vast majority of the time, most leukemias are going to be the acute lymphoblastic, or ALL. The cause of leukemia can be varied. It can be due to possible infectious agents, genetics, chromosomal defects such as Downs, immune deficiency states, fetal exposure to ionizing radiation, which is why, as nurses, you guys all need to make sure that you wear the lead aprons when you are at the bedside and shooting x-rays with your patient. Or it can be caused from chemotherapy. Basically, the pathophysiology is instead of going through the normal mitosis to make new cells, these crazy cancer cells clone themselves and they fill up the bone marrow with abnormal cells. So basically, the leukemia comes in, it takes over white blood cell function, and it doesn't even allow the marrow time to make the correct cells. It just screams at the marrow, make cells, make cells, make cells. So the marrow just makes bad clones. The leukemia takes over the good white blood cells, it hijacks the bone marrow, shuts down production of your red blood cells and platelets. Interestingly enough, although the white blood cell production is high, the actual white blood cell count in labs is low. So, you should know that in leukemia, you have a low white blood cell count. These leukemic white blood cells are not viscous, or they're not vicious and mean. They don't try to attack things. But it's survival of the fittest out there, so there's some competition for metabolic resources. The clinical manifestations of leukemia include anemia, infection from the neutropenia, and bleeding due to the decreased platelet production. One of the other hallmark characteristics is joint or bone pain, and this happens when the leukemic cells invade the periosteum and cause extra pressure within the bones. Leukemia can also spread to the liver, spleen, and lymph nodes. It can spread to the CNS and cause increased ICP. And if it invades the testicles, then it can often cause painless swelling and edema. Leukemia is diagnosed basically off of lab work. The blood count will reveal anemia, neutropenia, and thrombocytopenia. A peripheral blood smear may reveal immature forms of leukocytes, often combined with the low blood cell counts. The definitive diagnosis comes from a bone marrow aspiration, which will be hypercellular and show blast cells. Children may also have lymph node, liver, or spleen enlargement. Once the diagnosis is confirmed, then a spinal tap will need to be done to check for any CNS involvement. The treatment for leukemia involves chemo and radiation. There are 4 phases for the chemo. There's the induction phase, in which you get maximum cell death. Cells that survive this phase are going to be more resistant to treatment. I listed out some of the meds that you would see during phase 1. I don't care so much that you know exactly which drugs go in which phase. I basically just put the names of the chemotherapy drugs in there just so you could see them and kind of be familiar with them. Vincristine and the L-asparaginase are both there. I just wanted you guys to see these names and kind of recognize that those are all chemotherapy drugs. And I don't really care that you know where they are in the phase. I just want you to see them in case you see them on boards or exams or something like that. So after 3 to 4 weeks, when a remission has occurred, then the CNS prophylaxis begins in conjunction with cranial radiation. Radiation and additional drugs can be used for CNS disease as well as intrathecal methotrexate. So that's when they actually put in like a spinal, and they'll actually put methotrexate directly into the spinal fluid. During the intensification phase, the goal is to eradicate any residual leukemic cells, followed by delayed intensification, in which the goal is to prevent any resistant leukemic cells from cloning. Drugs in the delayed intensification are used to target leukemic cells that may have survived. So it's kind of like we've nuked them again, We're going to come back one more time, make sure that nothing else is surviving, and just to be on the safe side, we'll just nuke it again. And then we go to the maintenance or the remission phase, and those drugs are listed out for you there. Maintenance therapy continues for 2 to 3 years, causing decreased immunity, not surprising, and an increased risk for infection. What's the difference in a bone marrow transplant and a stem cell transplant? The process is pretty much the same. It just depends on where the cells for the transplant come from. A bone marrow transplant means that the stem cells come from the bone marrow and are transplanted back into the patient. In a stem cell transplant, that stem cells, your bone marrow, there's little stem cells in your bone marrow that escape all the time. So at any given point in time, your peripheral blood may have some stem cells circulating in it. So with a stem cell transplant, they can give patients some CSF, and that will stimulate the release of stem cells. Then they harvest the stem cells from the peripheral blood. They are collected, and then they are transplanted back into the patient. The difference really comes down to just where the cells come from. Now, stem cell transplants don't come, well, and the same for bone marrow. Any kind of cell transplant, it does not come without risk. There is risk for sepsis, for severe organ damage with stem cell transplants, as well as the risk of graft versus host disease. So there are two types of bone marrow transplants, autologous and allogenic. Autologous means they take the child's own marrow, usually from a non-diseased area of the body. They check it for malignant cells. They're going to clean it up, store it. They're going to do massive chemo, and then they're going to go back and reinfuse it. Autologous transplants can be used to treat solid tumors such as neuroblastomas, lymphomas, rhabdomyosarcomas, Ewing sarcoma, and Wilms tumor. Autologous can also be from the child's own cord blood if it was banked after birth, possibly from a sibling as well, because as you guys know, cord blood is also rich with stem cells. Basically, for a bone marrow transplant, they're going to harvest the stem cells first, then they do massive chemo. Think about it just like a nuclear bomb. They're going to nuke, and they're going to just like shut down everything they can in the body almost. There is a huge infection risk during this time because you are basically obliterating and wiping the immune system out. Then they reinfuse with stem cells and wait for the immunity to come back. So, we'll get to the nursing care for that in just a minute. This slide is important because this is important. Well, this is the kind of stuff that boards is going to ask you. What is the nursing management for a child who has undergone a bone marrow transplant? Number one priority, prevent infection. That is your number one nursing priority, okay? Prevent infection because they have no immune system during this time. You're going to put this child in protective reverse isolation. Wash your hands, no fresh fruit, no flowers, nothing. Sterile environment. It's very boring. It's very miserable for the child and for the family. Number two, control the bleeding. That's your second priority. You're going to limit invasive procedures. No IM shots, no rectal temperatures. You don't want to do anything that you are going to puncture or damage any kind of skin or mucosal surface because you have no immune system. Okay, the skin is like all you have, basically, so you have to protect it. If you have to do an injection site or change your IV site, you're going to maintain pressure on the site for at least 5 minutes because, again, you've wiped out your marrow. You don't have a lot of blood cells, period. And then, of course, you'll transfuse with red cells or platelets as needed. Maintain nutrition, hydration, monitor for signs and symptoms of rejection and graft versus host disease, and provide emotional support. This is more nursing interventions, more things that you would do in managing the care of a patient with leukemia. You need to always manage and watch for problems associated with drug toxicity. Some of those things are listed out for you there. These are some of the side effects of medicines, or can be symptoms of drug toxicity too. Care is centered around managing side effects, the safe administration of meds, and monitoring labs. You're going to have to maintain hydration and nutrition, which is hard. It is so hard. Um, when kids are undergoing cancer treatment, they're not hungry. Nothing sounds good, nothing tastes good, nothing smells good. So when they get a craving and they want something, you make it happen. If they start craving Chinese food at 3 a.m., you call and you get Chinese food there at 3 a.m. as soon as you can, because in 30 minutes, in an hour, that craving may pass. And then by the time the food gets there, kids are going to look at it and be like, ew, I don't want that anymore. You have to feed them when they get the craving. So let them have whatever it is they want. And psychosocial support, that's a really cool video. I'm going to try and just post it on your page because I seriously doubt any of you guys are actually going to click on it and watch it. But um, I'll post it. But it kind of goes over psychosocial support. It's fun.